Yes, Roshan.
Moment 3, 2, 1. We are live now. Over to you.
Yes. Good afternoon, one and all, and a very warm welcome. I'm Dr. Charvi Prajapati from Medical Affairs team at McLeod's Pharmaceutical. So as we all know that prevalence of diabetes mellitus is growing worldwide, and India is home to 77 million diabetics, which is second highest in the world, followed by China. Diabetes is associated with significant microvascular and macrovascular complications. More than 65% of patients with diabetes die of cardiovascular disease. In order to understand various aspects of diabetes management and role of sulfonylureas, we have with us Dr. N. C Krishnamani. Roshni, next slide, please. Dr. N. C Krishnamani is Director Cardiologist at Fortis Hospital, Delhi. Sir was past Director and Head of Cardiology at MGS Super Specialty Hospital and has more than 35 years of clinical experience. He has special expertise in primary coronary interventions and has more than 15 publications by his name in national and international journals. Sir has also contributed to various chapters in medical books and is member of prestigious organizations like ICC, IHA, INC, CSI, and many more. It's an honor to have you, sir. Now I hand over to you.
Good afternoon and good evening, one and all. At the outset, I would like to thank Dr. Prajapati for having given such nice introduction about me. And in fact, the topic which I would be speaking about would be Dapagliflozin, bridging the gap in management of heart failure with or without diabetes. And Dr. Prajapati had actually said about the diabetes, because being a cardiologist, we are dealing with more heart failure patients and maybe with or without diabetes. Well, anyway, the incidence of heart failure in individuals with and without diabetes, we know that from the Framingham study, which has got a follow-up of about more than 20 years, the incidence is quite high. It's coming to be almost about 2 to 3% in non-diabetics, and diabetics, the incidence is quite high, from 7.6 to 11.4. And in the patients who had actually, different studies have come out with different. But overall, we see that the incidence of heart failure is very high in the natural population with or without diabetes. Of course, diabetes adds to almost about 1.5 times more than the natural, the histories. In India, heart failure is a very big challenge. The current estimates of the heart failure vary between 1.3 to 23 millions. And in fact, in India, 1 out of 3 patients are readmitted, and 1 and 3/3 the patients, they die within 1 year of their productive years. This is very important, that most of the patients in India, they are in the productive life years, which is a big economic challenge to our society. And diabetes and heart failure are very closely linked together. And we know that from the various associations, especially the American Heart Association, there's a 2-fold increase in likely to develop heart failure. We see irrespective of the spectrum, wide spectrum of the age group, diabetes is always makes a patient prone for heart failure. And diabetes, heart failure, and renal dysfunction, however, this vicious cycle is, correlated. And this is the type 2 diabetes, which intensifies. It's a major risk factor for diabetic kidney disease. It's a major risk factor for heart failure. Heart failure intensifies the type 2 diabetes. And both of them will lead to actually cause a sodium retention, and ultimately sodium retention leads to the heart failure. And it is very important for us to know that the heart failure is defined as a clinical syndrome characterized by dyspnea, fatigue, exercise intolerance, and fluid retention. And this is how the fluid retention by sodium, retention is actually by heart failure and kidney disease occurs. And this leads to a significant morbidity and mortality in the patients. The vicious cycles between type 2 diabetes and heart failure, these are all the various mechanisms of how the insulin secretion decreases, which causes hyperglycemia, which causes microangiopathy, myocardial infarction, leading to myocardial necrosis, decreased calcium handling, leading to heart failure, and of course, in sarcomere stiffness, which leads to heart failure with preserved ejection fraction and endothelial dysfunction, microangiopathy leading to inflammation and fibrosis, and also increase in the RAS and the sympathetic activation, which leads to lipolysis or lipogenesis and gluconeogenesis in obesity, leading to a vicious cycle of leading to insulin resistance. So they are all interrelated, and they are going in a vicious cycle. The pathology of diabetes and heart failure the diabetes causes hyperglycemia, insulin resistance, and hyperinsulinemia. And this again is the same slide as the previous one, which is presented in a more of a way, in a chart way. Inflammation, dyslipidemia, endothelial dysfunction leading to coronary artery disease, leading to ischemic cardiomyopathy. And of course, these hyperglycemia and the insulin resistance and hyperinsulinemia will lead to cardiomyocyte hypertrophy, RAS activation, a calcium handling, fatty acid utilization, and autonomic dysfunction will all leads to diabetic cardiomyopathy, and this leads to heart failure in diabetes. The cardiomyopathy in diabetes can be heart failure with preserved ejection fraction, with reduced ejection fraction, and moderately reduced ejection fraction. All the three varieties occur in diabetes. Heart failure in type 2, what are the therapeutic options? We do have various anti-diabetic drugs like biguanide, sulfonylureas, then TZDs, GLP-1, DPP-4-1, SGLT2, and insulin. Of course, the interest of today's talk will be SGLT2 inhibitors. What are the guidelines recommendation for the diabetes with heart failure? It's an extremely busy slide, and we see that in all the guidelines, particularly the ADA 2020 had included the SGLT2 as one of the prominent place, in the heart failure and treatment. Suppose if we lead in a patient's heart failure or CKD dominates in a diabetic, preferably SGLT2 with evidence reducing heart failure and CKD progression. This is evidence-based, and this ADA has actually included SGLT2 inhibitors, quite in before we adopt to the other treatments also. And in the AD and ESD update 2019, again, the SGLT2 were actually occupying a prominent role. And associations of glycemia, the risk of cardiovascular events, this is again a similar slide. Various drugs, especially the anti-diabetics, and their association with heart failure. We see that major cardiovascular events and heart failure hospitalizations, the hazard ratio is most of the drugs, they do have a protective role or in terms of major cardiovascular events in the heart failure hospitalizations. The American Diabetes Association and the American Heart Associations, both these have actually included SGLT2 as one of the prominent, the class of drugs which decreases the heart failure. This class appears to be promising for treatment of heart failure in patients even without diabetes. This is in the AHA 2019. The SGLT2 inhibitor bridge the gap of the missing link in cardiorenal syndrome with or without diabetes. Also, the key unmet needs in heart failure and cardiorenal diseases actually are the patients who have cardiorenal syndrome. The RAS inhibitors and the diuretics can be beneficial but can worsen the renal functions. This is what is the key unmet need. What is the best drug to be used in such situations? And also another control is that the treatment is reliant on the management of comorbidities or the symptoms, and also the proportion of patients receiving guideline recommended doses of ACE inhibitors, beta blockers is as low as 22 to 12%, respectively, in patients with comorbid renal conditions. Cardiorenal efficacy of the newer anti-hyperglycemic drugs, in particularly primary and secondary prevention, when you were talking about SGLT2, GLP-1, RA, and DPP-41, we see that the events, particularly the SGLT2, the heart failure and the diabetic kidney disease, they are both decreased by SGLT2, whereas this particular action of the positive effect on the renal in diabetics is absent in GLP-1 and DPP-4. And also the secondary prevention, also all the parameters, that is the MACE, the heart failure, and the diabetic kidney disease, that all these three parameters are favorably affected by SGLT2 receptors. And the choice of glucose lowering medication, these are the patient examples. In a patient who was like a 68-year-old, the typical clinical presentations, 68-year-old woman at high risk of heart failure and diabetes, hypertension, hyperlipidemia, and coronary artery disease, creatinine 1.1, EGFR 55. The best treatment option is metformin, followed by SGLT2, because this may decrease the risk of cardiovascular events and risk of heart failure hospitalizations. Whereas the GLP-1 receptor agonist may decrease the risk of, but we have a positive role of SGLT2 in such a scenario. And DPP-4 are actually contraindicated in this scenario. In the second case, 78-year-old male with diabetes, recently diagnosed as stage 3 heart failure with reduced ejection fraction caused by non-ischemic cardiomyopathy, EF about 30%, creatinine 1 and EGFR 77. The way we treat would be a metformin followed by an SGLT2, which may decrease the risk of heart failure hospitalizations. DPP-4 have to be avoided, and also GLP-1 receptor antagonists have to be avoided in this sort of scenario. Another common situation is 59-year-old male with diabetes and recently diagnosed stage 3 heart failure with preserved ejection fraction EF about 60%, creatinine 1.1, EGFR 71. And again, these combination, the stepwise, the metformin and second SGLT2 inhibitor may decrease the risk of heart failure hospitalization. And also in this sort of scenario, we like to avoid DPP-4 inhibitors. Last in the situation will be 72-year-old female, diabetes, stage 3 heart failure by ischemic cardiomyopathy, creatinine 2. We, of course, the choice of lowering medication will not be SGLT2 in this inhibitor. Of course, there are trials of SGLT2 inhibitors at eGFR of as low as 20, but it is better to be on the safer side, not to use at the beginning. And the SGLT2 inhibitors bridging the gap in heart failure management with or without diabetes, the first class of the cardiovascular mortality risk, they decrease the cardiovascular mortality and heart failure risk. And this is the only class with cardiorenal benefits with or without diabetes. And of course, these are the ones which are recommended by the latest guidelines also. Kidney is involved in the regulation of glucose homeostasis via 3 different mechanisms. That is the release of glucose into the circulation via gluconeogenesis, uptake of glucose into the circulation and to satisfy the energy needs, and also the reabsorption of glucose into the circulation from the filtrate to conserve glucose. And the how do the SGLT2 inhibitors cause and how they are related to the glucose management. The SGLT2 inhibitors affect at multiple sites in the diabetic kidney. A novel insulin independent mechanism by reducing the renal tubular glucose reabsorption, producing a reduction in the glucose blood glucose without stimulating the insulin resistance. This is a novel mechanism, and the SGLT2 inhibitors enhance the natriuresis, cause intravascular volume contraction and alter the intrarenal hemodynamics, which likely to contribute to beneficial effects on the blood pressure, body weight, and albuminuria. There are some pleiotropic effects that have translated into reduction in the cardiovascular events and the preservation of the kidney function, and in large cardiovascular trials also. Again, this is a very busy slide, but how do the SGLT2 have a cardioprotection? This is by decreasing the cardiac afterload and preload, increase in the myocardial oxygen supply, increase in the cardiac systolic and diastolic function, decrease in the MACE and the risk of heart failure. Similarly, the SGLT2 also have a nephroprotection that's decreasing the intraglomerular pressure, decreasing the blood pressure, and decreasing the progression to CKD. And how do they again act? This is very important when you are talking about SGLT2, decreasing the MACE and also decreasing the hospital readmissions and mortality of benefits. The SGLT2 decrease the glucotoxicity, improve in the cardiac fuel energetics, increase weight loss, decrease adiposity, decrease the inflammation, decrease the plasma volume, increase the hematocrit and hemoglobin, decrease the systolic blood pressure and arterial stiffness. This is how the mechanisms do occur with the SGLT2. Sodium glucose cotransporter 2 inhibitor cardiorenal protection. This is how this is again similar to that, only like ultimately the natriuresis and glucoseuria are the ones which are the basics So then what are the mechanistic rationale for investigating SGLT2 inhibitors in heart failure beyond type 2 diabetes? Diabetes and heart failure have similar pathophysiological features, therefore affecting the endothelial and the insulin resistance. So therefore, this is what is important, that how do the heart failure patients respond to SGLT2 and by a diabetic drug? This is what is the explanation given. Mechanistic effects of SGLT2 inhibitors are also seen in patients with or without diabetes, and these are by diuretic effects and the metabolic efforts. The diuretic effects are natriuresis and glucoseuria, and the metabolic effects are increased glucagon and increased ketone bodies. Cardiovascular, there are cardiovascular benefits of SGLT2 inhibitors are largely independent of the glucose levels. And also, when you go down to the mechanisms, what are the molecular mechanisms are they regarding the outcomes relating to cardiovascular benefits? Specific mechanisms have not been fully elucidated, but several mechanisms like preload decrease, the afterload decrease, improvement in the myocardial metabolism, alteration to inhibit the sodium pump channel in the cardiac myocyte, which eventually leads to the reduction in the intracellular calcium, and also affecting the heart myocytes in remodeling. It's very, very promising mechanism. At the level of the kidneys, and in addition to glucoseuria by direct inhibition of the glucose reabsorption in the proximal convoluted, anti-inflammatory activity has been noted. Blockage of SGLT2 channels causes decrease in the glomerular pressure and also tubular hypertrophy, and the consequences that amplified by the afferent vasoconstricting mediated by the direct action, and this is also affected positively by the SGLT2. And of course, the comparison of the cardiovascular indications for SGLT2 for patients with heart failure with type 2 diabetes, the indications to use the SGLT2 inhibitors are heart failure like dapagliflozin is used, MACE, cardiovascular death, dapagliflozin, and these are the trials actually, Dapagliflozin and empagliflozin for the cardiovascular death. These are the various trials which have been and parameters checked in the double-blind trials. The dapagliflozin is the only SGLT2 with a cardio benefit actually, and with majority of the primary prevention. The first and only FDA-approved SGLT2 for patients with heart failure with reduced ejection fraction with or without diabetes. This is the first drug which was coming into practice. No other SGLT2 is indicated for to reduce the cardiovascular death in patients with heart failure with reduced ejection fraction and with or without diabetes. DAPA also offers a novel pathway that complements the current therapies in the heart failure with reduced ejection fraction, that is decreasing in the kidney by decreasing the glucose sodium reabsorption, increases the glucose excretion, increases sodium to distal tubule, increase urine production. This leads to decrease in the plasma volume, decrease in the systolic blood pressure, and in the heart there is a decrease in the pressure which the heart feels. That's called as the preload. There's also a decrease against which the heart pumps. That's called as the afterload. The other thing, important thing of the SGLT2 is the outcomes, the decrease in the plasma glucose levels and neurohormonal effects by downregulation of the elevated sympathetic activity. The downregulation of sympathetic activity decreases to reduction in the preload and afterload, and therefore increased improved survival in heart failure with reduced ejection fraction. These are all the mechanisms. What are the approved indications of SGLT2? The approved indications are type 2 diabetes as an adjunct to diet, exercise to improve the glycemic control in adults with type 2 diabetes mellitus, to reduce the risk of hospitalization for heart failure in adults with type 2 diabetes, and also establish cardiovascular disease and multiple cardiovascular risk factors. The heart failure, it's indicated in heart failure to reduce the risk of the cardiovascular death, the hospitalization for heart failure in adults with heart failure, particularly class 2 to class 4 symptoms. And the dosage, the recommended starting dosage is 5 milligrams once orally, taken in the morning with or without food. And in patients tolerating dapagliflozin, 5 milligram once daily would require additional dosage for glycemic control. The dose can be increased to 10 milligram once a day. To reduce the risk of hospitalization for heart failure in patients with type 2 diabetes and established cardiovascular disease or multiple cardiovascular risk factor, the recommended dose of dapagliflozin is 10 milligrams orally, and heart failure recommended dose is 10 milligrams orally once a day. These are the various, DAPA trials with educating the endpoint as cardiorenal efficacy. And we all see that the majority of the SGLT2 inhibitors, basically, they do have a neutral or a positive reduced effect of the heart failure is reduced, the diabetic keto, the kidney disease is also primarily favorably affected. Sorry. And out of all the drugs, if you see, dapagliflozin has got a neutral effect on the primary and the secondary MACE points, and heart failure is reduced. The secondary and heart failure is reduced. The diabetic kidney disease is reduced, and the secondary diabetic kidney diseases are decreased. So therefore, if you compare all the anti-hypoglycemic drugs, and particularly the recent one, the SGLT2 inhibitors, the DAPA has got the most favorable effects on the favorable on the outcomes. The major trial which published in that is the DAPA heart failure trial, which has actually made a paradigm shift in our thinking of SGLT2 and in the practice of DAPA use of the SGLT2 in heart failure, is the DAPA heart failure trial. This is a trial which is published, started in 2009. It was actually published in recently also. This was to evaluate, that's a 2-year effect was recently published. And this was a trial to evaluate the effects of SGLT2 inhibitors in patients with established heart failure and regardless of the presence or the absence of type 2 diabetes. This is a phase 3 trial, and the composite endpoints were worsening of the heart failure and the urgent visit to the, and also leading to the cardiovascular deaths. We find that among the patients with heart failure with reduced ejection fraction, the risk of worsening from heart failure from cardiovascular diseases actually causes a lower, lower among those who received DAPA than as compared to those who received placebo. Dapagliflozin actually helped in saving lives by significantly reducing the cardiovascular death or hospitalization for heart failure. And again, DAPA kidney disease, DAPA in kidney disease. Again, this is one of the side arms of the DAPA-HF trial. And this also had actually come out with the endpoints as the studied was actually the kidney failure. And it was found that among the patients with chronic kidney disease, regardless of the presence or absence of diabetes, the risk of a composite of a sustained decline in the estimated GFR at least 7 or at least 50%, the end stage kidney disease or the death from renal or cardiovascular causes can be is significantly lower with the dapagliflozin than the placebo. The trial, which has again included SGLT2 and chronic kidney disease, is that dapagliflozin with or without saxagliptin given addition to ACE or ARB treatment is a potentially attractive option to slow the progression of the kidney disease in patients with type 2 diabetes and moderate to severe kidney disease. And the finding of this, trial, DELIGHT trial, is actually confirming, giving us more confidence and use of DAPA in patients with heart failure and kidney disease. The derived trial, actually, these findings were support in the positive benefits and risk of the profile of DAPA for treatment of the patients with type 2 diabetes and chronic kidney disease. The other trial, which had the RED trial, which had actually shown that the trial's results demonstrated that the SGLT2 dapagliflozin lowers the MGFR, mean GFR, beyond the sugar control on top of the standard care and including the RAS block in metformin treated type 2 diabetes patients with or without overt nephropathy. And clinical trials that expand the population we benefit from SGLT2 inhibitors are the Emperor reduced DAPA CKD, that is the chronic kidney disease. And we see that SGLT2 are used in many situations, particularly in type 2 diabetes. It controls the ischemic control, causes the ischemic control, diabetic ischemic, and in the patients with type 2 diabetes without diabetes, the benefits are beyond glycemic control. That is the heart failure with the reduced ejection fraction, and also the patients who are having an GFR. The Emperor reduced and DAPA CKD trials showed that the SGLT2 reduced the hospitalization for heart failure and occurrence in heart kidney endpoints in patients with or without diabetes, demonstrating that the organ protection is due to factors beyond glucose lowering. Therefore, comorbidity inherent in the cardiorenal syndrome is elevated with the use of SGLT2 inhibitors. This is a very important message. There are many trials going on, and the DAPA ACT is like patients who have been use of dapagliflozin in patients acutely admitted with acute LVF or acute coronary syndromes. DAPA VO2, that's a functional and capacity, and dapagliflozin in heart failure patients again been used in this particular trial. dictate heart failure, that is the use of dapagliflozin in acute heart failure, is again trial. This is again very important for the clinical point of view, that these are all very bedside patients where if they go into heart failure, we put along with the other standard care of heart failure, along with the SGLT2 DAPA-MI trial, DAPA in acute myocardial infarction. Again, this is a very recent trial which is used, which is actually finding out the use of DAPA in acute MI. Any patient coming with STEMI, or who is along with the standard care of treatment for STEMI, we also start DAPA in these sorts of patients. And what is the dapagliflozin has got a very bright future, and dapagliflozin does what we want from the drug. It improves the symptoms, it improves the survival, it reduces the hospital admission. Then there are more than 80 trials going beyond the glycemic control. That is the dapagliflozin preserved in ejection fraction, dapagliflozin heart failure with readmissions, dapagliflozin and effect on the cardiovascular events and the acute failure or thrombolysis in myocardial infarction, head-to-head comparison of DAPA and EMPA, DAPA on nightmare blood pressure in type 2 diabetes, DAPA evaluation to improve the lives of patients with preserved ejection fraction, dapagliflozin in patients with diabetics with decompensated heart failure, the efficacy of the and safety of the dapagliflozin acute heart failure, and these are the various trials actually going on. And dapagliflozin in respiratory failure, dapagliflozin effects on the symptoms of biomarkers of the heart, a patient with heart failure, dapagliflozin on hypotensive heart failure patients who have after the sacubitril and valsartan treatment. Well, anyway, these are all the various directions in which the dapagliflozin is actually being used in the diabetic or non-diabetic with heart failure. And in now, to bridge the gap, SGLT2 class recommended by the reputed and the world bodies, that is ADA, FAST, ACC, in the management of type 2 diabetes with asymptomatic atherosclerotic coronary cardiovascular disease, the heart failure, CKD, or reducing the hypoglycemic and weight gain. There are more than 350 completed trials and proved that the role of dapagliflozin in glycemic and control and beyond. The landmark like the COT trial, let's say, cardiovascular outcome trials like DAPA HF trial have shown the survival benefits in heart failure with or without diabetes. And dapagliflozin is the first and only FDA-approved SGLT2 inhibitor with heart failure or with reduced ejection fraction and without diabetes. No other SGLT2 is indicated to reduce the cardiovascular death in patients with heart failure and reduce ejection fraction with or without diabetes. The future is very bright with DAPA molecule and a much needed molecule that bridges the gap of heart, kidney, and the blood glucose. Thank you very much for your kind attention. I'd like to definitely respond to whatever questions which I can be of some benefit. I'll stop sharing my slides. I'll stop sharing.
Yes. We'll check if there are any questions here.
ये participant. Question. She's muted. Joseph.
I think there are no questions.
Okay.
Okay. So thank you very much, Dr. Krishnamani, for your wonderful explanation and clinical insights on SGLT2 inhibitors, Dapagliflozin. It was really well articulated and presented. And thank you so much.
Thank you. Thank you so much.
Roshni?
Okay.
Thank you.
Yeah, now I think